Live attend. Oh, no.
Hi everyone, welcome to today's webinar on navigating the transition from pediatric to adult or neuroimmunology care. My name is Nell. I'm a 16-year-old with neuromyelitis optica spectrum disorder, and I'm one of the two junior patient ambassadors to the Sumire Foundation for NMO and MOG. And a little bit about the Sumire Foundation. It is a patient-led, patient-focused foundation that's dedicated to research and supporting the whole patient community with NMO and MOG. And my story in relation to the foundation. So I was diagnosed when I was 9 years old, and for a long time, I felt very alone in my diagnosis. I didn't know anyone else with my same condition, nonetheless, especially a kid with my same condition. So it wasn't until during COVID I discovered TSF and went to actually one of the book club meetings, and it was incredible to meet other patients for the first time who understood my experience. And so since then, I've been involved in advocacy and patient days and a lot of amazing events that TSF has provided. So I just want to thank Sumaira and the Sumaira Foundation for hosting this webinar today. And with that, I will pass it over to you, Dr. Khan.
Great. All right. Well, thank you, Nell. Also wanted to thank Sumaira and the foundation for having us today. I'm going to share just a couple of slides. Let's see. Here we go. So I have the pleasure today of just doing sort of a quick introduction of our program and then the three speakers that we'll have today. So our program here, some of our faces, comprises a multidisciplinary group of clinicians, all with expertise in pediatric neuroinflammatory diseases. We serve a very large area, including the Washington, D.C. area, Maryland, Virginia, parts of West Virginia. We're also available for national and international referrals. Our goal is always to tailor our visits to the needs of each individual patient. Ours is obviously a pediatric population, so from the very young up until someone turns 22. And that's where we're here to talk about sort of those older age groups and how we transition from our clinic into adulthood. Our patients will always see at least one of the three neurologists, and then depending on their physical, emotional, or cognitive needs, we'll see one of our rehabilitation doctor, neuropsychology, social work. Not listed on this slide, but we also work with a wonderful rheumatologist as well as a psychiatrist. But the core group here is included, and just wanted to say that a lot of what we're able to do is run both our clinical care sort of in parallel with a lot of observational research as well as clinical trials. And we couldn't do any of that without our amazing clinical care coordinator, Haley, and our clinical research coordinator, Claire. So I want to make sure that we mention them because when it comes to actually the nuts and bolts of doing something like what we do, it really all falls on them. So we have three speakers today, and our goals are to cover a couple very big areas. And so hopefully we'll be able to get out the big important things and then have some time for questions. The first topic is going to be covered by Dr. Alexandra Kornblue, and she's going to talk about NMOSD and MOGAD, specifically highlighting adult versus pediatric differences. So Dr. Kornblue is a pediatric neurologist who is fellowship trained in both pediatric multiple sclerosis and related demyelinating diseases. Her specific research interests include a focus on MOGAD as well as on clinical trials. And she's spearheaded several published case series as well as retrospective cohorts to describe interesting case presentations and treatment outcomes in the area of MOGAD literature. She serves as the director of the investigational therapeutics through the Children's National Pediatric Neuroimmunology Program and acts as the principal investigator on several of our clinical trials. Emily Stein will talk next, sort of about the nuts and bolts of transitioning into adult care. She'll highlight sort of transition readiness and talk about our experiences that we've had with sort of clinical flow and transition support. Emily is an experienced clinical social worker with expertise assisting families with chronic diseases. She has a special interest in the role of mindfulness-based interventions as well on mood and fatigue in pediatric demyelinating conditions. And prior to joining our neuroimmunology team, did a lot of work on transition to adult care in the congenital cardiac population as well. Lastly, we'll hear from Dr. Cole Haig about supporting young adults with neuroimmunological conditions from a neuropsychological perspective. He will focus on the role of neuropsychological evaluations, fatigue management, accommodations for school as well as in the workplace, and then strategies for self-advocating in the healthcare system and with transitions. Dr. Haig is a clinical neuropsychologist, also with specific expertise in neuropsychological assessments of children and adolescents with neuroimmune conditions. He spearheaded several research efforts with us here at Children's National as well to study the neuropsychological outcomes of children with MOGAD and related diseases. So that's what we have in store. And with that, I will hand over to our first speaker, Dr. Kornblum.
Thank you so much, Dr. Khan. I am just going to share my slides too. All right. Can you see my slides? Perfect. All right. So it is a pleasure to speak with you all today. As Dr. Khan mentioned, I'm one of the pediatric neuroimmunologists in our multidisciplinary clinic. I'm very excited to be able to chat with you today about this really important topic. So I have no disclosures relevant to this presentation. Today, we are really going to focus on some of the key neurologic differences between adult and pediatric features and then care of neuromyelitis optica spectrum disorder and MOGAD. We're going to start out really focusing on NMOSD, and then we'll shift to MOGAD in the second half. I apologize, I'm having one issue with my slides here, so I'm just going to try to fix it really quick. All right, that's okay. All right, so starting out with NMOSD, we're going to go through the prevalence, the clinical presentation, the disease course, differential diagnosis, treatment response, differences in disease-modifying therapies, and prognosis comparing pediatric and adult populations. This concept really highlights that adult and pediatric providers have different expertise and expectations for their NMOSD patients across different age groups, which is very paramount to this topic of transitions of care. So starting out with some prevalence information, NMOSD can actually affect patients of any age, but this disorder is much more common in adults than children. In adults, the median age of onset is around 40 years of life, and in pediatrics, NMOSD is really quite rare. We certainly see pediatric patients in our clinic with NMOSD, but it is not very common. Only about 1 to 1.5% of children with acquired demyelinating syndromes have positive aquaporin 4 antibodies and fall into this clinical category. Just as an example, one study was conducted in Australia looking at 67 kids with demyelinating syndromes. And in that whole cohort, only one child ended up being positive for aquaporin 4 antibodies. Children aged 10 to 12 years are most likely to be affected by NMOSD, and multiple studies have demonstrated that the mean age of onset is around 12 years old. So overall, it seems that the pre-adolescent to early adolescent age group is particularly susceptible. This is just for your reference. I know many of you affected by NMOSD are familiar with the core clinical characteristics. This table is from the most updated diagnostic criteria for NMOSD, now not so updated anymore. It was published 10 years ago in 2015. But the core clinical presentations include optic neuritis, myelitis, area post-trauma syndrome, and then a few less common presentations that are listed in the red box here. focusing in on differences between adult and pediatric patients. So the clinical features really do vary with age. In adults, the sentinel attack typically involves the optic nerve or spinal cord in more than 85% of cases. Common presentations include optic neuritis, which is usually unilateral or bilateral visual loss, change in color vision, and ocular pain. And then also adults often get transverse myelitis, which causes limb weakness, sensory loss, and bladder and bowel dysfunction. In pediatrics, NMOSD often presents with more frequent and severe brain involvement compared to adults. Pediatric patients are more likely to experience encephalopathy, seizures, and brainstem symptoms. Area post-trauma syndrome, which is characterized by intractable vomiting and hiccups, is also more common in pediatric cases. Here are just some sample MRIs to demonstrate the clinical features of NMOSD. Again, in adults, optic neuritis is more common, and you can see in the images on the left here, inflammation in the optic nerves pointed out by those yellow arrows. And then adults are also more commonly affected by transverse myelitis, which you can see an example of in the image on the right, with inflammation pointed out by the white arrows affecting a large portion of the spinal cord. And here are some examples of the more common pediatric presentations. So children are more likely to have inflammatory brainstem lesions. On the left, you can see an example brainstem lesion from a case that we took care of at Children's last year in a 16-year-old. The arrow is pointing to a brainstem lesion with edema, an abnormal signal on the MRI because of infiltration that's in an area of the brain called the pons. She had presented with new onset double vision and vertigo and had some headaches, and then after a big diagnostic journey was found to have positive aquaporin 4 antibodies and was diagnosed with NMOSD. Children are also more likely to have area post-trauma syndrome, which again occurs in NMOSD due to inflammation in a structure called the dorsal medulla in the brainstem, and that can cause intractable vomiting, nausea, and sometimes hiccups. In terms of the disease course, so across the age span, the disease course occurs in acute attacks, then followed by periods of remission. That's demonstrated by this graph on the bottom here, where the orange triangles show discrete relapses, culminating in disability over time after each relapse. In adults, the attacks are often severe and can lead to significant disability if not promptly treated. Unfortunately, pediatric NMOSD tends to have a higher frequency of relapses. Children may experience more rapid progression of symptoms and a higher likelihood of multifocal attacks, which can involve either simultaneous or sequential involvement of multiple central nervous system regions. When diagnosing NMOSD, it is important to keep in mind that other conditions could be mimicking the symptoms and MRI findings. We're going to go over this a little bit more in a couple minutes, but overall, pediatric populations have a much higher prevalence of MOG antibodies compared to adults. And adults, again, more commonly have the aquaporin 4 antibodies. Because these disorders are now fully understood to be distinct, it is very important to make an accurate diagnosis. The graph on the right here shows the frequency of MOG antibodies and their titers, as well as their titers, which are higher among children compared to adults. And we'll go over this again in a couple minutes. And then shifting to treatment differences. So the treatment response also varies between pediatric and adult patients. Pediatric patients tend to respond better to acute treatments like steroids, intravenous immunoglobulin or IVIG, and plasmapheresis, showing significant improvement in clinical outcomes. But by contrast, adults may require more aggressive and sustained immunosuppressive therapies to manage relapses and prevent disability progression. In the past few years, there's been an explosion of disease-modifying therapies approved for the chronic treatment of NMOSD in adults. This chart summarizes their mechanisms, their dosing, and safety monitoring for the main drugs that have been approved. That would include eculizumab, inebilizumab, and satralizumab. All three are thought to be highly effective for preventing relapses in NMOSD. None of these are yet officially approved for pediatric NMOSD, but there are some clinical trials in process to seek FDA approval. So thinking through some of these pediatric clinical trials, just to fill you in. So the first one is studying eculizumab. It's no longer enrolling, but this trial did recently end, and we're waiting on the results to be published eagerly. Ravulizumab is another study drug that's a cousin drug to eculizumab. Here at Children's National, we are a site for this study, but have not yet enrolled any patients. Inebilizumab is another drug under study in the pediatric population that's already been approved in adults, as well as satralizumab with an ongoing study in pediatrics. The most common medication that's used in the treatment of pediatric NMOSD actually is rituximab, which is used off-label in many pediatric neuroimmune conditions and seems to have quite high efficacy for NMOSD, both in pediatrics and adults. And then finally, the long-term prognosis also differs between the two groups. Adults tend to have a higher expanded disability status scale, or EDSS, at follow-up compared to pediatric patients. Data suggests that adults tend to have a more aggressive and severe disease course overall. And by contrast, pediatric patients are more likely to respond favorably to acute treatments. Although pediatric patients may experience frequent relapses, the overall disease progression in terms of disability is slower compared to adults. So that suggests that while children may have more relapses, the severity and impact of the relapses is overall less pronounced. So now we're gonna shift gears and focus on the age-related differences in MOGAD. Again, I'm seeing differences in prevalence, clinical presentation, disease course, treatment response, and prognosis. And these differences underscore, again, the need for age-specific diagnostic and therapeutic strategies when we manage MOGAD. So with regard to prevalence, I alluded to this earlier, but again, MOGAD can affect people of all ages, but appears to have particular predilection for children and young adults, and we see this much more commonly in our clinic. Both incidence and prevalence are higher in children compared to adults. And this graph on the right shows a comparison of over 60 studies looking at patients with acquired demyelinating syndromes. In this really large data set, the authors of this research study demonstrated that the frequency of MOG antibodies and their titers are higher among young children than adults or adolescents. Oops. As many of you know, not all patients with MOGAD have the same clinical presentation. The core demyelinating events that occur in MOGAD attacks, per the newer diagnostic criteria that were published a couple of years ago, are listed out here. The major clinical manifestations are these various demyelinating syndromes, which include optic neuritis, myelitis, and acute disseminated encephalomyelitis, abbreviated as ADEM. Patients can also present with a variety of cerebral monofocal or polyfocal deficits, as well as brainstem or cerebellar deficits. And then non-demyelinating clinical presentations are also increasingly recognized, essentially a version of autoimmune encephalitis, which we call cerebral cortical encephalitis. A key point about MOGAD clinical presentation is that the clinical phenotypes vary with age. So in younger children, typically those who are prepubertal or less than about 11 years of age, ADEM-associated phenotypes are the most common presenting features. And then in older adolescents and adults, we see that more of the opticospinal phenotypes like optic neuritis, myelitis, or a combination of the two, and brainstem lesions is more prevalent. This is just another way to present that information. So this figure represents a culmination of nationally acquired MOGAD cohorts from 6 different countries. The graph on the far left demonstrates that optic neuritis is by far the most common onset feature overall. But then when we divide the data into pediatric and adult groups, you can see that ADEM is more predominant in children. And again, optic neuritis is most predominant in adult patients. Focusing in more on just the pediatric population, so various studies have looked at the prevalence of MOG antibodies in pediatric acquired demyelinating syndromes. The bar graph on the left here is showing pooled data from 11 studies, and you can see that MOG antibodies are present in about 1/3 of all pediatric patients with acquired demyelinating syndromes. Others show that even up to 50% of new demyelinating syndromes in kids are due to positive MOG antibodies. And then the pie chart on the right here shows the clinical presentations that we see among pediatric MOGAD patients at disease onset. So to summarize the differences in MOGAD clinical presentations, again, adults more frequently present with isolated optic neuritis and transverse myelitis, or a combination of the two. In addition, unilateral or one-sided optic neuritis is more common in adults compared to kids. But by contrast, ADEM is more common in children, and in pediatrics, we see a higher frequency of encephalopathy and seizures at MOGAD presentation. Also, bilateral optic neuritis, where both eyes are affected, is more prevalent in pediatric cases. Again, here's some MRI examples just to illustrate the different clinical presentations. On the left, you can see MRI pictures showing inflammation in the optic nerves pointed out by those red arrows. Bilateral optic neuritis, where both nerves are affected, is more common in kids. And then the picture on the right shows some classic MRI features in ADEM with lots of different areas of inflammation affecting different parts of the brain. In terms of the MOGAD disease course, some patients have monophasic disease where they only have one attack of inflammation, and then other patients have multiphasic disease where relapses unfortunately continue to occur. There's a depiction of this in the graphs on the right. A picture of a monophasic disease course is shown at the top, and a relapsing disease course is in the picture on the bottom. Sometimes there's not full recovery of function between relapses, and patients can be left with residual disability after each attack. In general, adults are at a higher risk of multiphasic disease and tend to have a more chronic and relapsing disease course than kids do. The time to first relapse is shorter in adults compared to pediatric patients as well. In pediatric cohorts, we see that children with MOGAD more often have a monophasic disease course, with a significant proportion achieving complete recovery even after that initial MOGAD attack, and relapses are less frequent in children compared to adults overall. The exact rates of how often we see relapses is really variable across research studies. It's difficult to compare the different studies because of different designs, different populations, and different follow-up periods. And then with regard to response to treatment, so pediatric patients generally have a better response to acute treatments and a lower risk of long-term disability. IVIG has been particularly effective in reducing relapse rates and improving outcomes. IVIG is overall less commonly used in adult populations than in pediatric ones. And adults tend to have a more chronic and relapsing disease course and may require more aggressive and sustained immunosuppressive therapy to manage relapses and prevent disability. There are currently no FDA-approved therapies or published randomized controlled trials for disease-modifying therapies in adult or pediatric MOGAD. Really, all long-term treatments are based upon expert opinion and retrospective research studies. However, there are a couple of actively recruiting clinical trials for both children and adults with MOGAD. The first one here is a phase 3 study that's looking at several centers at a medication called satralizumab in MOGAD. This is a pediatric and adult study. They're recruiting patients age 12 and up with relapsing disease. And then the second study is just going on in adults, so patients 18 years or older, another phase 3 trial looking at a medication called rozanolixizumab, which is used in a different autoimmune condition called myasthenia gravis. We look forward to the results of the ongoing clinical trials and more prospective studies in the future to really help guide our treatment for both children and adults with relapsing MOGAD. And then finally, shifting to prognosis. So this is a graph from an example research study looking at MOGAD outcomes. This is from a really large cohort of about 250 MOGAD patients out of the UK. And in this big research paper, 47% of patients were left with permanent disability from their MOGAD. Their outcomes data is presented in the graph here based on age group. So the youngest patients are shown in the bars on the left and then the oldest on the right. Patients with the white bars showed full recovery and the darker bars showed worse recovery. And overall, it's showing that more patients in the younger age group had full recovery. This demonstrates that overall we see a better prognosis in children compared to adults. To summarize the prognostic information, so adults with MOGAD tend to have worse functional outcomes with higher disability scores. They are also more likely to have persistent MOG antibodies and a higher risk of long-term disability. And by contrast, children generally have better functional recovery and lower disability scores at follow-up, and a higher proportion of pediatric patients achieve complete recovery compared to adults. So overall, just to summarize, in both NMOSD and MOGAD, there are key differences in the demographics, the clinical presentation, the disease course, the treatment course, and the prognosis. Those differences underscore the need for tailored care in diagnosis and treatment strategies when we manage these disorders across the different age groups. Both patients and providers should have awareness of the nuances of managing these diseases in adults versus pediatric patients so that we can all work together to optimize outcomes and support an effective transition across the age span of neuroinflammatory disease. I just have some references here. And again, thank you for having us speak to you today.
I'll go ahead and jump in. I'm going to go ahead and share my screen as well. Okay. So as Dr. Khan mentioned, my name is Emily Stein. I'm the social worker for the neuroimmunology team at Children's National, and I'm really happy to talk with you guys about the concept of transition and the process by which patients transition. So something that's really important to think about is that we do call transition a process, meaning it's not a moment in time. It's a step-by-step procedure, and it's a goal to help patients slowly over time develop skills and ask questions and learn so that when it is time for a pediatric patient to move on to their adult provider, they feel ready and they feel confident. So we do have a transition program here at Children's National helping our patients, but it is possible that many of you out there might go to an institution where there isn't a specific transition team. And so the good news is that just because there might not be a team doesn't mean there aren't tons of resources. And there's actually a really wonderful resource through the Child Neurology Foundation. They have a transition of care program. It's a bunch of free resources. And a lot of the ways our program works are tailored to this program. We used a lot of their resources. And so I thought kind of before going through our specific program, talking about different aspects of a transition program and what might make it successful for you. And if your program doesn't have a transition program, maybe some of these concepts can be adapted to you for your team. So they have this really great stepwise program of 8 different steps, and we're going to run through those all today so you guys get an idea of what you want to be thinking about at each different step of transition. So just starting with step number 1, which is going to be our expectation of transition. Okay, so what does transition on your team mean? And how does your team do this? What age do they actually have their patients transition from a pediatric to an adult provider? And then thinking about, who's going to be responsible, who's going to help? Is there a program? Is there a coordinator? And what does that all look like for wherever it is you might be getting your medical care? And then thinking about, how am I going to assess myself? How am I going to learn what it is that I know or don't know about the transition process? And a great tool for this is a yearly self-management assessment. And so as you get older, it becomes really important to take more responsibility for your medical care because this is going to help you feel more prepared when it is time to transition. And these yearly self-assessments can help you learn what it is that you know and what it is that you don't know in order to establish goals and think about the things that you want to be working with your team on. So as I said, the Child Neurology Foundation has some great resources. And in our clinic, we do use their transition readiness assessment, which I'll be showing you more specifically a little later on. But this is one of the web uploads for it. So it's something that you can look at later as well. So the next step is going to be thinking about an annual discussion of your medical condition and any age-appropriate concerns. So are you talking with your doctor on a fairly frequent basis about some really important topics? So things like your medical condition. So what is it that you know about what it is that you've gone through and what that will mean for your life? Are there any medications that you're on and any potential side effects? Any signs and symptoms of any concerns you should be aware of? Is there any genetic counseling or reproductive implications of your condition? Any issues related to puberty or sexuality? Any alcohol or driving or substance abuse? Any risk factors you should be thinking about? And then any emotional or psychological concerns related to your wellness. So as I said, your doctors might be talking with you about this preemptively, But if you're noticing that there's something on here that you haven't had a discussion about or you have questions about, maybe just make a note of it and think about that for your next appointment, asking your doctor, you know, how does this apply to me at my age? What should I be thinking about? And thinking that about, you know, in that regards to your steps towards transition and becoming more comfortable with your medical care. So the next one that comes up is this idea of legal competency. So some of you out there might be under the age of 18, meaning that your parents are still legally responsible for you, but one day you will turn 18 and you will become legally responsible for yourself, which is exciting and scary and all the things at one time. But for some patients, in some situations, a patient might require a legal guardian and or a power of attorney. So a legal guardian is somebody that's appointed by the court to manage somebody's personal and financial affairs. So it's a legal process in which maybe a parent or your medical team might determine that it's in the patient's best interest to have somebody appointed to really remain involved even through adulthood. The next one is the idea of a power of attorney. So this is a little bit more of an optional thing for a patient that you might just feel like it's something that you might need. It's a written authorization that somebody can remain involved to represent or act on behalf of somebody's various interests. So this one is a little bit less permanent, doesn't involve the courts. You can just create it for yourself and it can be revoked at any time. And it's just a way to keep people involved if that's something that you should want. So again, you know, as you're nearing the age of 18, just thinking about what does that mean for me and my legal competency. So the next one we want to think about is an annual review of our transition plan of care and really thinking about any transition goals. So maybe you've been giving yourself that annual self-assessment, you've been deciding on some goals, you've been thinking about some things you want to work towards, and you've created those goals. And some of those might be some of these listed here. So maybe you want to learn about your medical insurance or filling prescriptions or about pre-authorization. So how are you doing that? How are you talking about it? And are you getting these questions answered? So you want to sort of review that for yourself, even if your team isn't preemptively doing it, right? That's something you can keep track of. Again, there are so many wonderful free resources. They actually have like some guidelines and some timelines of things where you can really write down your own plan of care if it's not provided for you. And the next one is the child neurology team responsibilities. And this is when we're getting a little bit closer to transition and thinking about who's going to actually help us prepare our package of our records of all the information that our adult provider is going to need to know about everything that's happened to us through our entire pediatric course. So is that something you're going to have to do on your own? Where do I do that? Or is there someone that's going to help me? And will that person then get that package to our next provider? And what is that package? What does that even look like? So here's a bunch of different things that you might consider going in that package. So it could be a transfer letter, a final transfer, transition readiness assessment, a plan of care, an updated medical summary, any legal documents, a condition fact sheet, and any additional provider records. So once again, you know, you're going to want to go to your adult provider with some information. What's happened to you? What is it that you need? It's your unique story. So how are you going to get that together? And the next being the identification of an adult provider. So is someone going to help you with this? Or are you going to have to go out there and look for this on your own? And if you're going to have to do it either way, there's some important components you want to think about, right? So you want to think about their expertise. Do they have experience with patients like you? Do they know how they can help you? And that's going to be a pretty important question when you're thinking about somebody. Again, location is going to be important too. Are you moving? Are you going to college? Are you taking a new job? Is your transportation situation changing? How are you going to get to your new appointments? Thinking about that new provider and what makes sense for you from a location perspective. Now, schedule availability is going to be very important for obvious reasons and maybe some more complex reasons. So sometimes, you know, for some of you patients out there, you might be taking medications or you might be on an infusion schedule. So some providers might require an appointment before they'll start prescribing you new medications or even your old medications, right? So thinking, does this provider have availability to see me before I need my next infusion or my next prescription refill? So we want to make sure whoever it is that we're selecting really can meet our needs. Okay, and then our goal, right? Our last step being our transfer is completed. And so we consider our transfer complete when a patient has had their appointment with their new provider. So as I mentioned, we do have a transition process and a transition team at Children's National, and we try to work our best within the goals that I just sort of outlined. So we have a transition team comprised of a social worker and a nurse coordinator who work in conjunction with our physicians. We assess our patients every year from the ages of 16 to 21 to really understand where they're at in regards to what they know and what they don't know. And we try our best to set some good educational goals for them. And we begin really thinking about transition planning, like the actual process of moving on to their next doctor around the age of 18 to 20, and really start to prioritize them as educational needs. Our more formal phase of transition begins at the age of 21. We might start preparing their package with the goal to transition them at age 22. And so social worker or myself, we would reach out to the family to start talking about the actual transition process. We'd work with the neurologist to identify an adult provider. The patient's going to make that first appointment because now you're 18, right? You're legally responsible and able, and that's going to be a big first step and hopefully something you've practiced beforehand. And then the last step is that our nurse coordinator is going to fax medical records to your new adult provider. So that's our step, and that's our process. But again, even if your team doesn't have something like this, it doesn't mean that you still can't practice a transition process that's going to make you feel safe and comfortable and confident. And there's all those wonderful free resources that can help support you through that. So I know this is a little bit hard to see, but I did put the link on this screen, so I can also share this with the webinar if anyone wants to check out this self-assessment. So this is the one that we use in our clinic. It goes over self-care aspects, it goes over medical questions, and it also goes over using healthcare. So from my perspective, as the person who gives this assessment, I am finding that most of our young adults, the biggest area of questions are going to be around that using healthcare component. So healthcare is a very complicated world. It's very confusing, and there's lots of stuff to learn, right? So we really do in our clinic try to go over stuff in a stepwise fashion and teach people things slowly so it doesn't feel too overwhelming. But I thought today, for the purpose of this webinar, that perhaps I'd go through a couple of the common areas that some of our patients are often asking questions, just so we can kind of check those off your transition list. And so the first one being insurance, which is a really overwhelming and scary and, wild world. So where do you get your insurance? So if you're a patient out there right now, I want you to go ahead and ask yourself that question. And if you don't know the answer, that's okay. But maybe use this as an opportunity to learn that. So do you get it through your job? Do you get it through a federal health marketplace? Do you get it through Medicaid or Medicare? Or do you get it through your parents' insurance plan? And once you learn that, start thinking about what are some of the requirements of keeping that insurance? Is that something that has to be recertified every year? Is there open enrollment? What does it mean for me then to keep my insurance, and how long can I keep it for? So those are going to be some really important questions as you age and as you grow up, thinking about where you get this very important health insurance that you want to always be with. Also, in addition to where do you get your insurance, but what does your insurance mean? And so once you have your insurance, you do have your own insurance card. It might be through your parents. It might be, again, through your work. It might be through the state. But typically, you're going to have an insurance card with your name on it and your own policy number. But there is some really important stuff on your insurance card that you're going to want to be aware of. And a lot of that is around the world of paying, right? What you're going to have to pay to go to the doctor. And that's going to be in this area of number 4, which is copays and coinsurance amounts. So what does that mean for you? What do you have to pay to go to the doctor? And then also really thinking about what doctors can you go to? Who is going to be in network, meaning your insurance provider has a deal with them. They're ones that's going to be provided, your medical insurance can be provided at a higher level versus somebody that's out of network, meaning that there's going to be less coverage available for you, so therefore more out-of-pocket expenses. So that's going to be an important aspect for you to start to learn. Another area that's really important on your insurance card is just honestly the back area, which has all the numbers for any questions that you might have. So what I'm going to encourage all of you out there to do is to, number 1, think about where I get my insurance. And number 2, take some time to familiarize yourself with your insurance card. And if there's information on there that's confusing or you're not understanding it, maybe ask your providers, ask your parents, And, take that time to just check that off, because for a lot of people, insurance can be very, very stressful. The next one is the concept of medication refills. So that is something that is really important, making sure that you have everything you need in a timely manner. So how do I refill a prescription? And before you can even do that, you want to be aware of when you're even going to need to refill a prescription. So how many refills do you even have before you have to go back to your doctor and say, help, I need more? And you want to be aware of that, because things can't always happen like a snap of a finger, right? Sometimes there's stuff that has to happen before you can get a prescription refill. Sometimes you're going to have to do something as simple as calling your doctor's office, but other times you might need lab work or even an office visit before you're able to get that medication. So those are all things you really want to be aware of when you're thinking about handling your own medication. You're also going to want to think about, where do you go to get your medicine? Do you go in person? Do you call them up and get it by phone, or do you get it by mail? Lots of different options available to you, but just being familiar with what it is that you're doing now, so you have an idea of how you can do it in the future, when maybe it is totally up to you, if it's not right now. So those are just two examples of some maybe teaching goals and how we might handle them in our clinic, how we might help prepare some of our patients with different aspects of learning how it is to start to take more self-management of their own medical condition. And again, transition isn't a snap of a finger, something that we do at one time stamp. It's a process. We want to make sure that our patients are learning slowly over time. So when it is time to move on to their adult providers, they feel comfortable and safe and confident and able to handle it. So thank you guys so much. I really loved sharing this with all of you. I hope it was helpful, and I'll give it to the next person.
Thank you, Dr. Stein. That was really, really helpful, especially being someone who's 16 and about to start that transition myself. So
Very happy to share.
Hi, everyone. I'm Dr. Haig. I'm going to jump right into it here, but thank you all for the opportunity to be here today. Thank you, Nell, and thank you, Dr. Khan, for the awesome intros. And yeah, so I'm Dr. Cole Haig. I'm from the Division of Neuropsychology here at Children's National Hospital. I'm a pediatric neuropsychologist that's embedded in the neuroimmunology clinic, which I love. So happy to be here. Today, we're going to talk about something that is pretty near and dear to my heart, which is transition planning for folks, right? And I feel like this is a really important topic, I think, because as Dr. Kornblue and Emily alluded to, is that there's a lot of, I think, stress and concern about what's going to happen in the future. But there's also, as a nice positive reframe, there's also a lot of opportunity here to potentially, help a kid grow, right? So we're going to talk about some of that today. If I can click through things. Let's see. There we go. Okay, cool. So starting off with what neuropsychology is. So in simple terms, you may have read online, if you looked up neuropsychology at all, that this is about brain behavior relationships. Really what we're looking, what this is it's sort of the science and clinical assessment of how people's brains are sort of thinking and learning and getting around in the world. So we use tests to help us sort of tease out behavior, the thinking, the emotions of some of the folks that we work with. And when we're working with folks with neuroimmunological conditions, there's some specific cognitive domains that are commonly affected for folks that we want to make sure we pay special attention to. So processing speed is actually the big one. It's thinking about how quickly you take in and respond to information. It's like sort of the processor of your computer. And for someone with neuroimmunological conditions, if they're sort of if they're experiencing some processing speed challenges, it can kind of make things like time management and upkeep pretty tricky. So especially if environments are a little bit less structured and things like that. So things that are new as well, like college or a new job. So want to have that kind of domain on your radar. There's also attention and executive functioning, which is sort of your brain's air traffic control system. Recent events have certainly reminded us of how important that all is. And when these skills are challenged, things like time management, planning, organization, where to be, when to be there, and what you're supposed to be prepared for, those things are really important. Visual spatial processing is also something that we attend to. We know that can make it harder to navigate the world and kind of encode the things that are presented to you. Other factors also too, like your emotional functioning, fatigue, sleep issues, like these are all things that also have a bearing on your cognition and your daily functioning. But the important thing that I want to sort of give to people here is that this is not, neuropsychology is not just about ferreting out the deficits. We're also interested in your strengths, because what we do is we develop sort of a plan or a program to leverage those strengths against the areas of challenge. We'll talk a little bit more about that, but why do we do these? And why is it important when it comes to transition planning? So there are 4 main reasons that we do this. Well, 5-ish, but 4 that I want to talk about here. First, we want to establish a cognitive profile, so usually, or a baseline. So we want to, shortly after a person is diagnosed, we want to basically map out how that person's cognition is right now, so that we can also understand, you know, what you're sort of starting with and how we sort of track that over time. We want to also, of course, if we identify any areas of challenge, we want to accommodate that. We want to intervene. We want to help promote sort of the maximization of people's sort of abilities and functioning. The third, we know that some of these diseases have a tendency to change over time, right? As Dr. Kornblue was telling us about earlier. And so because of that, we want to monitor that to see if there are any changes that occur, and do we need to intervene. 4, we also really try to develop what I think of as sort of your personalized strategies. So everybody, I say this to a lot of the patients I work with, but everybody has a different sort of thinking and learning style. And so it's important for us to understand that. So again, we can sort of build a picture of what's going well and what are the things that are difficult, so that we can kind of leverage the areas of strength against the areas of weakness. I think the sort of like quasi 5th recommendation is that, so just so you all know, it's usually recommended, especially after a baseline evaluation, that you do an updated neuropsych evaluation every 2 to 3 years to track that progress. Now, with some of these folks with neurological conditions, that sort of schedule of how frequently we're testing might change. But I actually think a really important time to do an evaluation is around 14, 15, 16, because it helps us to understand what's maybe coming up for this kid and begin that transition planning kind of conversation and process. But of course, we do some of these neuropsychological evaluations so we can help folks get educational accommodations. So when young adults especially move into college or vocational training, we want to understand what accommodations would be helpful to them. The tricky part is often figuring out when to disclose your condition. There are pros and cons to that process. Some people, of course, worry about stigma, but there's sort of ways to go about getting accommodations in a way that is sort of proactive with a self-advocacy bent, that I think it's important that we still talk about. Research shows us that accommodations that tend to be particularly helpful are things that have to do with processing speed, visual spatial processing. You know, you can understand how if you're just sort of like a little bit of a beat behind, that having extra time on a test is going to be really, really helpful to you. Or if you are somebody that struggles with sort of, you know, seeing or appreciating some of these things that are far away, you know, having copies of notes and things that are given to you, it's not a cheat code, it's you getting access to something that you should have, right? So I think that those accommodations are really critical for folks being able to, you know, perform to the level that we know they can. Executive functioning challenges are often present in a lot of the folks that we work with, NMOSD, MOGAD. Organizational supports tend to be really helpful, and some more explicit sort of behavioral coaching too. We also can't forget about fatigue management. Cognitive fatigue is a huge thing across these conditions and can seriously impact performance. And that might mean you have to think sort of strategically about what's the right schedule for you. How do you maximize sleep and rest? Understanding your own energy patterns, et cetera. And a lot of this also has to do with communication and documentation, which we'll talk about a little bit more here as we go on. But fatigue management, since I brought it up, is something that I really wanted to talk about here. So here's the thing about cognitive fatigue, and I know I'm preaching to the converted on this one, but it's unlike physical fatigue, it's invisible, right? Other people can't see it, but it's absolutely exhausting for people. And I think that, you know, if we're to sort of think carefully about this, you know, we have to think about it, I think, sort of like a budget. And so, you know, scheduling thinking if you sort of start with a certain set amount of, energy throughout the day, it's important to schedule the tasks that are most important and perhaps the most sort of like challenging or exhausting or require you to kind of like recruit all the resources. Maybe scheduling those during a time of the day, perhaps earlier in the day when your energy level is going to be higher. Taking regular brain breaks, we recommend that, especially during things that are really, really demanding. Modify your environment to reduce cognitive load. That includes like physically, if getting around is requiring you to recruit more of those resources we talked about. Thinking about how you can modify the environment so that it's easier for you to navigate and there's not as much that's sort of like physically exhausting too. And then technology supports are something that I think are really, really important. And we have more and more every day that's helping us to sort of accommodate ourselves in whatever way we need. There's some key workplace considerations. So as young adults move into the employment realm, the neuropsychological sort of perspective on this, I think, is equally important. The disclosure decision at work, I understand, is complicated, and I oftentimes advise people to begin disclosure conversations sooner rather than later, assuming that they are in the mode of wanting to get some workplace accommodations. For NMOSD, there are things that I think of as being pretty important, like visual and cognitive supports. So things like, so for visual, like adjusted lighting, screen magnification, reducing glare for visual issues, because if we're reading off of screens for a long time, we know that that can really exhaust us. Cognitive challenges, flexible schedules, having tasks or projects kind of presented in a way that's more manageable for folks. Flexible scheduling too, I think, can be really helpful. Being able to work during the best cognitive hours that you have, working closely with your supervisors to kind of maintain that. Environmental modifications in your workplace, noise canceling headphones, if you're finding that it's hard to sort of focus and attend. I also recommend strategic task management, like I said before, which is like doing the harder things first, but you can do that at your job as well, right? Some of what I think a lot of us do is when we arrive at our jobs, we kind of do the easy stuff because we're sort of like, oh, the other things are going to take so much more time and effort and whatever. And actually, we have some research that says if you do those things first, a lot of the rest of the day ends up being less sort of fatiguing than maybe those early hours, right? So I developed, I made this little diagram here because I thought it could be helpful, but I think it's important to think about self-advocacy during this time, because it's something that I talk with a lot of patients about. It's absolutely critical in this transition to adult healthcare kind of conversation. Emily did a lot more of an explicit kind of rundown here, which I think is fantastic. But it's some things I'm just going to echo, right? So really knowing your condition, the medications, how your specific symptoms sort of show up, figuring out how to communicate that is also really important. So being able to clearly explain your needs, your asks, your questions, follow up on unresolved things. I think this is where that you can bring some of those executive function skills into the room and say, okay, well, I should write everything down and prep for this visit, right? Make sure you're sort of ticking it off as you're going through. Third, there's also the system navigation. So understanding your insurance and coordinating between specialists. And some of this is also important because one of the things that we haven't said here is that because these are really rare conditions and not everybody has sort of a, tertiary healthcare facilities that are really nearby with specialists like us, you might have to be, unfortunately, the person that's sort of like giving this information to your providers that because they don't maybe know as much about some of these things. So I think it's important to make sure that we're linking with any specialists that you're working with, and moreover to make sure that you can also communicate in a helpful way, what your needs are, what your symptoms are, and how to get the kind of healthcare that you need. The last thing I'm going to do here is just say there's some key action steps that I just wanted to highlight. So I would begin the transition planning conversation or scheduling around age 14. And that gives plenty of time, I think, to start the process, get certain, like a neuropsych evaluation on the books, and then start to think about sort of what the roadmap is for this kid coming down the pike. Definitely, I would recommend using assessment data and any kind of interventions or documentation that you've received throughout your life. So one of the important things is when you are looking to get accommodations and either at school or at work, you have to demonstrate that you've had accommodations at some point in your life, either educational accommodations, could be a 504 or an IEP, special education services. Or it could be in addition to maybe like a neuropsych evaluation. That kind of documentation provides evidence that you not only received accommodations, but you also benefited from them, and there's a medical justification for them. So using the data and the documentation that you have at your disposal, definitely working on conserving cognitive energy through some of the strategies that we used, building up your self-advocacy skills. So combining your knowledge of your condition with your communication skills, system navigation abilities. I really think a transition portfolio can be helpful. There's a couple folks that we have in clinic that actually have them, and they're really wonderful. They're these like color-coded binders with a lot of their information in there. And I think it's also really helpful to, Nell started out talking to us by saying, this whole experience, especially being a young person, can be really, really isolating. And so I think the sooner that you connect with other people, people that are your age, people that are older, you can start to, build a support system here of people that understand you, because this can be absolutely isolating. It can be hard. And especially when you're a young person going, this is rare stuff that's going on with me. It's important for people to feel like there's somebody out there that understands them. So that's the bulk of what I have. So I'm gonna pass it back. Stop sharing, importantly.
Thank you, Dr. Haig. That was very comprehensive and very useful. I definitely found myself relating to a lot of those things, like the fatigue management for sure is something as a patient that I've definitely had to learn to adjust to. I also want to shout out that Dr. Khan and Dr. Haig are two of my very wonderful providers, and I feel very fortunate to be able to get this kind of care. I think now we're going to be opening it up for questions from the audience in the chat.
I have a question. There are others.
Oh yeah, and by the way, this is my mom. And I don't even have to describe how much she has played a role in my entire journey. She's a radiologist herself and has an amazing knowledge of navigating the healthcare system. So I don't know where I would be without her today.
Art, even as a physician, I love a lot of what you guys have been talking about. This has been so appropriate for where we are right now. In fact, for spring break, we're going to go on college visits. So a lot of my thinking right now is about that. And I wonder if you all have had any kind of experience in supporting families and parents and students as they transition to college, specifically in the way of dorms, because I would imagine like some of these kids are like in these four-way dorms, they're like living right on top of each other. And I think that not only impairs sleep, but it also, I wonder, increases their likelihood of getting sick if somebody else is sick. So there are other parents who have advocated for their kids to get singles, but have come upon a lot of resistance. And I wondered if any of you have had any experience in supporting that.
Yeah, I think I can speak to that. So, I think we have a lot of experience writing accommodation letters for schools, for elementary school, middle school, high school. There's a great process in place. We know that when you have a medical condition, we can put in for a 504, which sort of gives our medical recommendations for extended time on testing and things like that. When you have a learning disability associated with that, the IEP can also be a huge resource where that is sort of more mandated towards what additional services you can get. So patients can get physical therapy, occupational speech therapy in school with an IEP as well. In college, it's a little bit more difficult because we're dealing with private institutions institutions, as well as different types of public schools, right? So each school sort of has its own Office of Disability, which is usually where you can get these services through, and its own process for doing that. So I do usually encourage all of our kids who are moving on to college to take a look at the website that, you know, that sort of lists what they offer. Usually there's an application process or something that sort of says what the requirements are, and to talk to someone when they do the visits, or to make a phone call to see what it is that they need in order to sign up and sort of get their information through the office. The accommodations that we can sort of help, again, it depends on the school and what they offer and everything. But we're always here to sort of help support with letters, medical information. And so it's tailored towards each individual child. I've definitely written letters asking for single dorms. We've written letters asking for preferential classroom like picking of your classes, right? So what Dr. Haig was talking about with the fatigue, if you do really well in the morning, being able to get morning classes is really important to you. Or if you need breaks between classes, so I need to not take 3 classes in one day, I need to spread them out, right? So we've written letters sort of asking for those accommodations, lots of different things. Us getting involved doesn't mean you're definitely going to get it, but it helps, and it helps to look early at what the Office of Disability offers and what forms and information, right, you need to fill out ahead of time. And then maybe Dr. Haig, you have something else to say. I think part of what you were saying too, in terms of repeating a lot of that evaluation, is doing that when you're getting ready to transition, so that we can identify maybe what those key issues are, because they might be different from what you did in middle school or high school to what you might need in college.
Absolutely right. Yeah, Dr. Khan is spot on with everything that she just said, as usual. The other detail that I would add to it is that some of these evaluations are good. It depends on the school, right? Like Dr. Khan was saying, some of the evaluations that are done for these kids, and when I say evaluations, I'm talking neuropsych evaluations. Some schools will take evaluations that are like 4 or 5 years old. That's atypical, honestly. Usually what I find is that most colleges and universities need an evaluation that's done within the past 3 years for them to consider the accommodations request, right? But I have had people say, well, you know, I gave them an old neuropsych and the school didn't give me any problems about it. But part of the reason that I mentioned sort of start the transition planning process, and that includes scheduling some of these evaluations around 14, is that if you time it right, you'll get an evaluation that's good for a fair amount of time that'll carry you through probably that first and maybe second year of college. I would recommend maybe that what you do is have an evaluation also like around 17 years and 11th grade. And I would do it prior to the summer before college. The reason being is because I would use that summer before college to maybe make sure you're working with the university that you have committed to at that point, to say, hey, you know, I'm an incoming student, I'm looking for these accommodations, and start the process early, so that way, once you arrive on campus, everything's already solidified for you. And one of the things that I think it's also important to mention is I have a bunch of folks who work, who are college students, and they're doing really well. Some of them are like, well, I want to use this accommodation, but I don't need this one so much. This one, you know, whatever. And what I tell people to do is, it's better to have it and not need it than need it and not have it, right? However, I think it's also important to, you know, empower people to make the decisions that they want to make. I think it's better to avail yourself of resources and to I think that's part of the self-advocacy discussion, but you can, you know, try to get everything in terms of accommodations, and then decide intermittently how you're going to use it and when you're going to use it. So that is another part of this.
Definitely. Thank you for that, Dr. Haig. I know, like, on my ILP, there are certain accommodations that I find like especially useful, and then some that I just use on like from a time to time basis.
Right.
So I agree with that statement. It looks like we have a question in the chat from another parent of a college-bound NMO student. Oh wow, graduation in 3 months. Congratulations. Her question relates to adjustment of infusion schedules to align with school breaks. Is it better to increase the spacing from 6 to 4 months on a one-time basis to create that alignment, or better to stretch the spacing out in the other direction?
I'm happy to answer that as well. Yeah, so we do this a lot. Ideally, if we can get on a winter and summer break schedule, and this is specifically talking about like rituximab treatment, because we break that up into about six months, right? Then we do our best to do that. Sometimes it's more like a Thanksgiving or spring break, or and it also depends on how far someone is. So if you're going to college where you can drive back, it's not such a big deal, right? But if you're going further away, then that can become more problematic. So there are a couple options. One, if you are going far away, we really encourage people to identify an adult neurologist in or around where their university is, right? So and that's also just for safety. So if you have a flare and you're more than a couple hours drive from your home institution, you need to know where you're going to go. You need to have a point of contact, and it's best to establish care so that the physicians there know who you are. So you're not showing up in the emergency room for the first time and saying, "Hey, I'm here. I have NMOSD. Here's my stack of records." So first and foremost, we say establish care with an adult neurologist. Go when you feel like you don't need a visit, right? You don't have any illness, you don't have any problem, your infusions are all set if that's done. With your records, meet them, find out where you would go if you have a flare, who you would call, all that kind of things. If you're far away, that neurologists may also be able to then take over your infusions too, right? That is an option. So you can think about that if that works better from a timing standpoint. And then second, for coming back, if the timing isn't quite lining up, we can do some things. So sometimes we say 6 months because your B cells we think are going to repopulate around 6 months, but maybe they won't. So we can check to see where they are and make adjustments and sort of move things up or move things back a little bit as needed and tweak it. So the answer is yes, we can do all of that. It needs to be done on an individual basis, and that we really do encourage everybody to find a neurologist and a point of care close to where they are as well.
Thank you, Dr. Khan. I know that's a big factor in like the whole college seeking process for patients with especially a rare chronic condition, because finding specialists can be pretty tricky, and just being near a major medical center is also a factor that probably plays into a lot of our own decisions.
I'll just echo what Dr. Khan said. I totally agree with all of those points. And with one additional point, that sometimes if patients are ending up going to college kind of closer to home and they're going to be in state, sometimes we can arrange to work closely with home infusion companies as well. We have lots of experience with that in our clinic. And so we can still be the primary prescribers for our patients if they're staying close enough. And actually they don't have to come to our infusion centers if it's a several-hour drive. But still having that sort of like local point of contact of what to do if there's a problem.
Definitely. I've actually had experience with home health myself. We started, I believe, during COVID is when the whole thing came along, but I actually get IVIG infusions from home, and it's been super convenient. I can do my little virtual school from home that day when I get my infusion, and it's really nice to not have to go all the way to the hospital just for that couple hours. I guess one thing I know, I used to be on rituximab. I'm now actually on the satralizumab, which has been amazing for being more compatible with my active lifestyle as a student. Um, with that, I guess I'm very curious, like when I go away to college, and managing getting those deliveries of that sub-Q injection to college and administering that, have you, I'm sure you've had experience with patients who take sub-Q injections in the past when they go away, so I'd love to hear more about that.
Yeah, so that goes to, I think, a lot of the points that Emily was making too, right? Which is about understanding what your medication is and what the prescription refill process is for that. So that is something that you would want to identify what a pharmacy, typically if it's a mail pharmacy, or if it's somewhere you need to pick it up, you want to familiarize yourself with how that medication needs to be stored. Make sure you've thought about that ahead of time, right? And that you've set up your environment to be able to do that. So those are all it's a perfect example of when you're sort of going through that readiness checklist, something that you need to think about. Okay, how often do I need to get refills for my medication? Does it get delivered to me? Do I pick it up? Where am I going to get it? And plan all that out ahead of time. And that's also actually a really great example to talk about for our other question too, which is that if at some point we're finding that the timing of the medication or the administration of the medication is no longer meeting what your needs are, we are entering an era where we have a lot more availability. In the pediatric world, as you know, it takes a long time for those medications to kind of trickle down to us. But we're here to advocate for switches in medication when we need to. And as more of these clinical trials result, I think this will become easier and easier for us to also transition to some of the other options that might work better for an active college student, right? Who can't come back and forth, or is more convenient not to have to come back and forth to their home to get infusions and things like that.
Definitely. I feel like we are so lucky in this community right now and this day to have these options that are more compatible with our lifestyles. And I know, Sumaira, do we have any other
Hey
questions?
guys, sorry, I'm doing two things at once. This was really great. Thank you all so much for being part of this. Maggie and Nell, you guys are a living, breathing example of transitioning from pediatric to adult care. It's crazy that Nell is almost an adult. We've been watching her grow up, all of us, before our eyes, and now she's winning awards, handing out signed books to presidents, and, moderating webinars and all the things. But none of this would have happened today, actually, if it weren't for Nell bringing us, an introduction to Children's National. So thank you all so, so, so much for this very informative webinar. Maggie, thank you for birthing Nell. She's incredible, and you're incredible as a mom, as a caregiver, as a radiologist, I'm sure, and to all the clinicians here. Such great, rich information that will help so many families who are trying to navigate how to transition successfully to adult care. So there is a lot of good information here. We'll circulate some of the links that have been shared in the presentations, but I wish you all a very happy NMO Awareness Month. And for anyone who wants to watch this again, it will be on our YouTube channel in a couple of days. So thank you all very, very much.
Thank you so much for having us.
Thank you.
Take care. Bye-bye.